Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Jorge Castillo, who is Associate Professor of Medicine at Harvard Medical School and Clinical Director of the Bing Cancer Center for Waldenstrom's Macroglobinemia, which is without doubt the premier Waldenstrom's Institute here in the United States, and probably the premier one worldwide, which has been instrumental in some of the key basic discoveries and in defining how we treat patients with Waldenstrom. So I'm very privileged today to have Dr. Castillo with us. Welcome, Dr. Castillo.
No, thank you. Thank you very much, Ravi, for the opportunity to talk about, a topic that is so very dear to my heart.
Thank you. So for patients, first of all, what is Waldenstrom's macroglobinemia?
Yeah, that's a great question, and we get asked those questions very often. At the Dana-Farber, at the Bing Center for Waldenstrom's, we are a group of clinicians that see patients with these conditions specifically. So we're two full-time physicians, and we have a nurse practitioner that helps us too. So between the three of us, we see probably about 60 to 70 visits per week on patients with IgM problems and Waldenstrom's. So one of the first questions that always come to our minds is, how do we define how do we diagnose Waldenstrom's in a proper way? So I would say nowadays we rely on three specific factors. The first factor almost always is an excess of IgM. That is one of the hallmarks of this disease. So what happens is there's these IgM producing cells that we all have them in our bone marrows, but in patients with Waldenstrom's, they have an overproduction of this IgM, and typically that is one of the first things that get diagnosed. Either a doctor sees that the protein level is elevated, or a doctor sees that the erythrocyte sedimentation rate is a little elevated, and they send a specific test called electrophoresis, and they find an elevated IgM or monoclonal IgM there. Now, once we find that monoclonal IgM, we still do not know what the diagnosis is, because there are benign conditions associated with IgM increase and some malignant conditions associated with IgM increase as well. So that's why the next step is actually to do a bone marrow biopsy. And the reason we go in the bone marrow is because the IgM producing cells naturally are nesting in the marrow. And so we do a bone marrow biopsy. And what we see in a patient with Waldenstrom's is that there is an excess of these IgM producing cells. We call them lymphoplasmacytic cells. Most of us should not have more than 0.5% of these cells in our bone marrows. So anything over 1% is abnormal. And again, we do have patients who have 10%, 40%, 80%, 90% involvement of their marrows, and that's a second feature of the disease. More recently, at the Dana-Farber, we detected a mutation that occurs in over 90% of patients with Waldenstrom's in a gene called MYD88, which is a gene that basically controls the function of these IgM-producing cells. So this mutation allows these cells to immortalize, and basically they don't die, they accumulate. So if a patient comes to see me in the clinic and they have an IgM elevation, they have this excess of lymphoplasmacytic cells, and then we have the MYD88 mutation, I think the diagnosis of Waldenstrom's in that specific setting is very certain.
So how common is this problem?
Well, not very common per se, which you wouldn't believe if you come to our clinic. We see 16 to 20 patients every day with this type of conditions in our clinic, but it is a rare disease. And I don't think we have a real, I don't want to say real, but at least a reliable, quantification of the actual prevalence of this disease. We believe that maybe there's anywhere between 1,500 and 2,000 new cases per year in the country. And that basically will give us a prevalence of maybe 30 to 40,000 patients with this disease in the country at any given time. It tends to affect older individuals in their 60s and 70s. However, we do have patients that have seen us in their 20s and 30s. And we have patients also in the 90s and crossing the hundreds. So the range of the age at diagnosis is very wide. but I would say most of the patients falls between their 60s and 70s. And most of our patients tend to be men. I think 2 to 1, I would say, men to women.
And so what are the symptoms that patients seek medical attention for with this disease?
That's a good question. So I think I want to emphasize that there is a group of people with Waldenstrom's who actually are asymptomatic at the time of diagnosis. And that's important because I would say probably about a third of the patients that come to see me in the clinic have the diagnosis of Waldenstrom's, but they are asymptomatic. And how does that happen, right? I mean, how can you be diagnosed with a blood cancer and have no symptoms from it? And again, as I said earlier, sometimes an elevated protein level can make the doctor think about doing more testing. Sometimes a very mild anemia that is not really causing the patient any symptom whatsoever sometimes prompts this type of testing. I have a patient, for example, that was walking her dog, and then the dog kind of ran away and kind of pulled the leash, and then she fractured her finger. And then they did an MRI, and the bone marrow looked a little heterogeneous in the MRI, and that's how the diagnosis was made. So there are a number of reasons, right, how these diseases can be diagnosed in patients who are otherwise asymptomatic. The importance of making that differentiation is because if you have asymptomatic disease, these patients should be left untreated. Obviously, over time, after the diagnosis, most patients will become symptomatic and will need treatments. I would say there's about an 80% chances at 10 years of needing, therapies because of symptoms. And I think this list here is actually very complete. I think the most common manifestations are the manifestations of anemia. Anemia is still the most common reason why we need to treat patients with Waldenstrom's. So fatigue, shortness of breath, just not feeling energetic enough, right, is one of the common classic manifestations. We have constitutional symptoms, right? I mean, the night sweats, drenching night sweats, the weight loss that is unintentional. We do have other patients who have enlargement of lymph nodes and organs, but again, those will need to be relatively large to cause symptoms, and in that way we'll need some type of treatment. In some patients, the IgM was very high and causes some hyperviscosity, right? And that can cause some retinal bleeds, and that can cause some vision abnormalities, that can cause some nosebleeds and some, blood clotting problems. We have other patients that can have numbness in their feet because of the IgM damaging the nerve endings per se. So as you can see, the clinical presentation of these patients is very diverse. And interestingly enough, sometimes when you see 2 or 3 patients with Waldenstrom's, they don't even have the same symptoms. I mean, the patient who has neuropathy almost never has hyperviscosity. And some of the patients who have hyperviscosity might not be anemic, right? So if you look at these patients, they seem to have different diseases. But at the end, if you look deeper, you will see the IgM, you will find the bone marrow findings, you will have the mutation. And that's how we use this umbrella term of Waldenstrom's macroglobinemia in these patients, even though the patients seem to have very distinct symptoms.
So I know you mentioned that you have, the 3 things that you look for to establish the diagnosis, but from a patient's perspective, what kind of tests do they have to undergo?
Yeah, so if somebody is suspecting that somebody has Waldenstrom's, blood tests are typically the first things that are done. And I think getting a complete blood count is always a good idea, right? In that sense, you can see how the hemoglobin is doing, which is affected, in most patients with Waldenstrom's. The platelets can also be affected up to some degree, but much less frequently than the red cells. And the white blood cells are almost never affected by Waldenstrom's, but again, it's something that we always checked. We want to know how the patient's other organs are doing, so we always get kidney function and liver function tests. We measure the IgM, which is one of the ways in which we will use to follow the progression of the disease. And when we treat patients, we will also follow the IgM because that will give us an idea if the patient is responding to treatment or not. But there are other immunoglobulins too that are not affected by the disease, like the IgG and the IgA, that we need to follow too, because as patients get treatments and the patient's diseases progress, they can see that the IgG and the IgS can get affected by it, and that can impact their immune system. In some scenarios, we also send some blood clotting tests. As I said, when the IgM was way too high, that can actually start using up your clotting factors, and some patients can have some bleeding problems. So we also check in some patients these type of situations. There's something called cryoglobulins and cold agglutinins. These are proteins that react to changes in temperature, and some patients with Waldenstrom's can have these formations of IgM, and they have very specific symptoms when they have these formations. I mean, they're not very common. I would say probably less than 5% of the patients have these findings. But we always like to know if these patients carry these special IgM formations, so we can be aware of what type of symptoms they might have. So once we have all these blood tests done, and we have a pretty high concern that the patient might have an IgM elevation or a Waldenstrom's problem, right there in the middle we see the procedure of the bone marrow. Right, this is how the bone marrow biopsy is done. So as you know, I mean, the bone marrow is pretty much everywhere in your body. Wherever you have bones, there's bone marrow. The reason we go right there in the hip is because it's easier, right? It's easier to get into the marrow in the hip area. It's not like it doesn't cause discomfort, but it's less painful than trying to get bone marrow from other parts of your body. So if it's done, following a good technique, I think this is a minor surgical procedure, and most patients should not have too much of a bad experience. But again, it all depends of who's doing it, and so it's important to have somebody with experience doing this type of test. And that's we're gonna get a piece of the bone, and then a piece of some aspirate from that, the liquid part of the marrow, and that's what is going to be sent for the mutation analysis and all that. On the right, we see the donuts. That's the CAT scan. All right. So yeah, that is something that we tend to use as well at diagnosis and when we're ready to treat, to make sure that there's no organ enlargements, liver and spleen very commonly, or lymph node enlargements we can see also with Waldenstrom. So all these are tests that we use for diagnosis and also for staging of the disease.
So obviously you mentioned this, and this is something that your team has really at the Being Cancer Institute for the Waldenstrom's really been pioneers in figuring out why people develop Waldenstrom's. And so can you just tell us what are the genes again that you are really looking for?
Yeah, as I mentioned earlier, the most common mutation that we find in patients with Waldenstrom's is this mutation in the gene MYD88. And over 90% of the patients that we have genotype at Dana-Farber, we have genotype a few thousand patients already, so it's very prevalent. Now, I want to be very clear here. The MYD88 mutation is not exclusive of Waldenstrom's, right? We do have some patients who have IgM-MGUS, which is a benign IgM accumulation. And about half of the patients with IgM-MGUS have already the MYD88 mutation. And then we have other cancers, right, like chronic lymphocytic leukemia or marginal zone lymphomas. Those patients, anywhere between 5 and 10% of those patients can have mutations in MYD88 as well. So MYD88 is not exclusive of Waldenstrom's, and I want to be very clear about that. But in the right context, right, in which you have the IgM elevation, you have the bone marrow involvement, and the MYD88 mutation, that's where we can use that information to help support the diagnosis. And actually, the MYD88 mutation was described in 2012. So it's almost 12 years, 11 years ago when it was described for the first time. But more recently in our laboratory, we have identified other mutations as well. CXCR4 is a mutation that we see in about 40% of patients. I think we reported on that mutation for the first time in 2016 or 2015, if I'm not mistaken. And more recently, we're now finding also mutations in TP53, which are mutations that have been seen in other malignancies as well. How do we use this information? So we can use MYD88 for diagnostic purposes when the cases sometimes are unclear. I think that can help support the diagnosis. But it can also help us with tailoring treatment options. MYD88, for example, whoever patients have these mutations, they can help us choose treatment options. And very appropriately, you put the list of patients of different options that can be used in patients with treatment. So MYD88 mutations, for example, support the use of BTK inhibitors. BTK inhibitors tend to work better when patients have MYD88 mutations compared to not having MYD88 mutations. And as you can see here, in terms of treatments, The number one is watchful waiting in asymptomatic patients. I think that is one of the most important messages that I can provide today. Sometimes the patient is anxious because they have a malignancy. The oncologist that is treating the patient is anxious because the patient has a blood cancer and maybe the IgM is elevated. But if the patient is totally asymptomatic, the quality of life of that patient is excellent. The life expectancy of a patient who is asymptomatic, untreated, is normal, like any other individual of the same age, sex, and race in this country. That's actually data that the Mayo Clinic published last year. So asymptomatic patients should be left untreated. And I think that is something that I don't think is going to change for the foreseeable future. I know that has changed a little bit in myeloma, with clinical trials and patients with high-risk disease and all that. But in Waldenstrom's, it's a bit different. And as you can see, there's a number of different treatment options that we can use in patients who are symptomatic. And that includes BTK inhibitors, which in my opinion is probably one of the most effective agents for Waldenstrom's. We have the ibrutinib, which is the initial agent, acalabrutinib and zanubrutinib, the most recent version. Extremely effective treatment. We have patients now crossing the 10, 11-year mark on BTK inhibitors, still taking them every day, controlling the disease very nicely. Chemotherapy has been the mainstay of the treatment for Waldenstrom for almost 20 years. Bendamustine, cyclophosphamide, extremely effective agents. We use them a lot. And what makes things a little bit complicated for us which is different than myeloma, is we don't have randomized studies, large randomized studies comparing these treatments. So we do use BTK inhibitors, and they're very effective. We use chemotherapy, it is very effective, but we don't have a study that has compared both in a prospective way for us to say, oh, this treatment is better, or this treatment is better. So it has to do a lot with personalization. We look at who the patient is, what symptoms they have, what other comorbidities they have, what are the goals that they have for their own treatments, whether copays are going to be, whether the side effects of the treatments are. So we have in mind all these other aspects besides efficacy to make these treatment decisions. Number 4, we have the proteasome inhibitors there, which we borrowed, from the myeloma world, extremely effective. We also combine them with rituximab. And more recently, we have now BCL2 antagonists like venetoclax that are, also showing high efficacy in patients with Waldenstrom's. And there's a series of clinical trials in which we're combining different agents to try to see if we can come up with more effective treatments. At the end, you put their plasma exchange, and this is something that we use seldom in patients with Waldenstrom's. It's essentially a process in which the patients get, a couple of lines either applied in the arms or in the neck, and basically the blood is taken out, filtered in a machine, and then sent back in with a replacement in plasma, and that's what is called plasma exchange. The beauty of that process is that we can, large molecules like IgM, which is very large, can actually be filtered out. So we use this plasma exchange in patients who have, for example, hyperviscosity, when the blood is too thick and is causing symptoms. We can actually do this plasmapheresis. We can remove that IgM from the system temporarily because, it's going to build up again. It takes usually a few weeks for that to happen, but at least it gives the patient some relief in symptom management. We do that also for cryoglobulins or severe cold agglutinins, in which we have to remove the IgM. But I want to be very emphatic that these type of treatments, this plasmapheresis should be temporary. It's just a temporizing mechanism to get the patient to a more definitive treatment. I don't think, plasmapheresis in your patient on a weekly basis, for 5 years is a reasonable approach. So we usually try to control the disease or the symptoms quickly, and then we start the patients on top of treatment afterwards.
So what is the prognosis of these patients? You mentioned that for patients who are asymptomatic, they live a normal lifespan. How about those who do require treatment?
Yeah, no, that's a good question. I mean, in my own professional life, I've been doing Waldenstrom's for almost 10 years now. I've been, member of the Dana-Farber Center for about 10 years. I have seen the prognosis of patients improving in my own professional, development, which is, I think it's an amazing thing. We have seen it in many places, right? We have seen higher cure rates for Hodgkin's lymphoma. We have seen prolongation of survival in patients with myeloma, which I think is impressive. 14 different agents in the last 20 years or something like that, which is insane. So we are seeing the same in patients with Waldenstrom. We are seeing that these patients tend to live longer. Now, I can tell you about my own experience in my clinic. I want to be also, full disclosure. The patients that come to see us at Dana-Farber tend to be patients, with higher incomes. They tend to be patients with, better performance status to be able to travel over the country to come to Boston. So it's not precisely the average, citizen in the United States, and to be younger patients that come to see us as well. So in our clinic, the median survival of these patients is clearly exceeding 20 years, and I think more than half of the patients will have that. But again, there are many factors that play in a role here. So if you are in the asymptomatic realm and you have been asymptomatic for many years before you become symptomatic, your disease, biologically speaking, is going to be a much easier disease to treat compared to a disease that, was diagnosed symptomatic and you are treating and the disease is relapsing relatively quickly. It's going to be a little bit more difficult, that the prognosis is going to be prolonged in that specific scenario. But I think with the advent of new treatments, right, if we have the chemo, when I joined the group, we had the chemotherapy and the proteasome inhibitors, and we were just starting the trial with BTK inhibitors. So the BTK inhibitors came, and that basically became one of the standard treatment options. And now the BCL2 inhibitors are coming up. We're doing all these combinations, and there are new generations of BTK inhibitors. And we haven't even talked about immunotherapies, right, which in myeloma and other conditions are really revolutionizing the therapies. Things like antibody-drug conjugates and bispecific engagers or CAR T cells, all those are actually clinical trials currently in patients with Waldenstrom. So my sense is in the next 5 years, we're going to have a lot of new treatments coming up that are going to impact the patient's quality of life. In my tenure, in the last 10 years at Dana-Farber, I think we have seen probably about 5 or 6 new agents being either approved by the FDA or endorsed by the National Guidelines Committee for the treatment of patients with Waldenstrom's. So it has been really impactful. And I think there are many reasons to be optimistic about the prognosis of these patients.
Well, obviously, your team there at the Farber is at the forefront of developing these new treatments and has already managed to change the outcome of this disease dramatically. And I'm sure we have a lot more coming from your team. So I really appreciate you taking the time out from a busy day to educate patients. And hopefully we will continue to see even more advances in this disease. I really appreciate you coming and spending time with us today.
Oh, no, thank you, Ravi. It has been great. I think a message that I can have for patients is, I always like my patients to be their own best advocates. And for that, I think it's important that they learn about their disease, that they share with their families and talk about this. I think that is the best way to move forward. And, whenever, myself and my group will be happy to be of help to anybody who would like to be seen by us.
You will help so many, and I'm sure you're going to help a lot more. Thank you for everything you do.
My pleasure.